If you're the meeting host, enter the host PIN followed by pound. If you're not the host, press pound. If you're the meeting host, enter the host PIN followed by pound. If you're not the host, press pound.
last month when we did it, we had a little bit of trouble with getting our webinar questions, so I might not have a lot of questions from the world.
Okay.
But we were trying to work on it, so hopefully it's supposed to be fixed this time. Okay, looking good so far. Okay, let's call Jan. Hey Jan, how are you? Good. You see me and hear me? Okay. Can you see my PowerPoint? Yeah, let me bring it up. It can't be this easy. There's no way. I know, but it was such a stress. All right, let me pull up from the beginning. Okay, you see an S? Okay. Now I'm no longer seeing my little window with the video, so you still seeing my face and hearing me? Okay. And are you seeing this video? Okay, so 16-second delay. Do you have sound on this video, Zach?
No, not that one.
What's that?
The sound is at the later on, like slide 17.
Okay. What are you seeing, Jen? Just me. Okay, you know what? I haven't shared my content yet. I know that. That's probably why. Okay, let's pull over to WebNX. Let's go to share. And should I share screen or share Microsoft PowerPoint? Just screen, right? Uh-huh. Okay, that's where I'm at now. Yeah, I'm okay. Yep, I've got those. I actually need to send you some new updated notes because I've actually cut out all the steps that she has that didn't make any sense. You're seeing me now, don't you? Aren't you? Okay. Okay, let me open the PowerPoint. Okay, I'm going to go to the first video. You see him moving? The little baby. Oh, we'll just wait a second. You'll get to the baby. I think we're just delayed. Are you seeing me? Right. But you still see me, don't you? In a little window off the side. But, okay. Okay, the baby's moving. Fantastic. All right, let's test some sound. Let me go to one of the videos that has sound.
17.
No, no. I'm going to the first video that has sound. It's definitely broadcasting in the room. Okay. Okay. Yeah, that's what the sound. We're listening for coughing. Oh, okay. Oh, okay, it's just delayed. You're like, whoa, this is way delayed. Nah, it's perfect. Okay, I'm excited. That was the easiest setup yet, knock on wood. All right. Okay. Okay. We're not starting until 2, so maybe 1:45. Yeah, perfect. I'm gonna start with an intro and then we'll just switch over to the PowerPoint. But text me if you see any problems or delays. Oh, did they finish or did they fix anything with the live chatting option? Are they still just not doing that now? Okay. Okay. Well, I appreciate all the time. No, no problem. Yes, it's definitely a lot better. All right. Okay. Sounds perfect. Okay. I will. Thank you so much. That woman is in my life. I'm trying to get you some better lights and videos from her. This is the most right room for
Yeah.
presentation.
It's like usually a good thing, right?
Yeah. One of the downsides of this type of presentation is you do have to stay pretty much in the window of the camera.
Okay.
And us tall people get a nice, chin shot.
Sure. Yeah.
But you can adjust it to where you like to stand. And be careful of all these cords because there's way too many of them.
Tinder, tell me about how I can do that.
Yeah, yeah. When you are selfieing, it is all about this.
Yeah.
In order to basically prove that they watched you online, if they watch you, they have to submit a 3-question quiz. Usually I just make up the quiz as I'm watching your presentation, but if you have any specific like points that you want to drive home, I can use those.
And the thing is like basically, we talked about the pediatric assessment triangle, basically the agnostic, localizing pathology, where the stairway sounds localized to, and then simple interventions to fix things.
To fix it. Okay.
Yeah, so they talk about, I'm sure
what I usually end up doing is, because we want it to be something where a lot of folks will go and archive and like take the 3 quiz questions and just scan the presentation for the quiz questions. So I actually try to pick something you talk about rather than something that's on your scans.
Okay.
So, but if we'll just pull them out and then people actually have to, it's a bit of accountability for the ones that are here, just get their certificates automatically, but actually I need to make sure he brings them with us. Are you going to want, I'm happy for this quicker in, but since you have to stay in front of the computer, you want it still?
Sure.
Mm-hmm. Okay. It let me bypass that for one day, but we're going to need to change those credentials to my email because Chris's no longer exists, period. screen picture.
That's awesome. That's amazing. Wow. That's so cool.
And yeah, they were basically like that for one solid day.
Wow. Wow. That's awesome. Oh, yeah, try.
Yeah, it worked really, really well. It is actually. Oh my, that's how it gets. It's working. It is working. Shockingly. Oh.
Do you need your attendance?
Yes. And I have the. I don't know how many we're going to have since we were missing last week.
Well, I'll be able to do it. I'll get her.
Yeah.
I'm going to do it off the computer and just have them type it in. Okay?
Yeah.
Because that way I can make sure I get the email right. We need to chat about it.
Oh.
Hey, Tia. This flow has stopped working. Is that a problem? Sure what the flow is. Is there a way to lower these curtains anymore for videos?
I was just running around pushing buttons. Ellen, do you know how to lower their curtains in here?
I don't know what.
Lower the curtains in here?
They're over here.
Oh, perfect. I don't know what that was. I think the computer's doing a bunch of like background work.
You want to lower it? Is it possible to lower it?
And Zach, just so you're aware, everything we do on the computer is actually broadcasting in the meeting room of PETOS right now. So,
Welcome to a Cisco meeting. You are entering the meeting now.
yeah, it's 16 minutes delayed.
This meeting is being recorded. You are the only participant.
Run through all your slides, basically showing that.
Okay, well, sounds good. So make one quick change.
And I believe it's still working. Push buttons since it's, sometimes. Yeah, I can. We don't have actual contact. This is supposed to notify whoever the guy is. We will do that.
And then it's an hour-long talk, but there's a little introduction and some time for questions, about 45 minutes.
Yeah.
Yeah.
Hey, Jen. Yeah. Yes. Yeah, public health. I have another computer here that you're just looking at recording on your cell phone. From the link within the WebEx. It says top chat. And do we have that option? live chat, live chat. Okay, I actually have that here, yes. So say something. So if anybody has questions, I can read it out to that. Okay, do I have to hit top chat? Is this top chat or live chat? Which one do I want? It says create a challenge, the channel to join the chat. PETOS add create channel. I do. So this isn't giving me any option to sign in. What this is doing is it just set up a PETOS admin channel. It's giving me the option of customizing the channel. And the webinar. Okay. Okay, let me go back to that other screen. Okay, so back to PETOS. More personal room. So welcome to live chat. Remember to guard your privacy, learn more, say something. But when I go down to the say something, the only option it gives me is to create a channel to join the chat. Maybe try to send somebody over. Try to figure out the chat options. See, the thing is, when I hit create a channel, it goes to YouTube and it has a PETOS admin with no subscribers. Uh-huh. Uh-huh. Oh, gotcha. Yeah, it says top chat, but it wouldn't let me open anything on the top chat. And now it just kicked me out of PETOS altogether, so I need to sign back in. Yeah, isn't that strange? Hello.
Hey, how's it going?
Good. How are you?
Good.
We're just wondering how low are the. Sorry, another lady. Yeah, that's where I was. Where you are.
Thank you.
You thought it'd be good, I don't know. You don't want to start touching that. Oh, I know. How that work? Thanks.
Thank you so much.
Hey, you know what though? Whatever you did on the PETOS now has a PETOS admin and say something. So when I click it, it says something. So let me write hello and then test and see what happens. Hey, whatever you did, I think I'm seeing stuff. That's a little better as far as the curtains go.
Yeah, definitely. Yes.
Are you seeing the hello? Because I can see it. Yeah, I mean, I can see it. Alan? Log into PETOS as another observer and see if you
I'm trying. Do we have a hotspot or something?
Yeah, I'm on hotspot on my phone.
Oh, mine's not.
I got a Wi-Fi code that's a one-time Wi-Fi code, but I didn't want to put all these computers on it because we've had problems in the past. So it's a pure, only presentation Wi-Fi. So we're just hotspotting our little computers here and we're watching it. You know what? I can check it on my phone too because I have PETOS on my phone. Me too. I'd rather you mess up yours over there too. Yes, and the little window that's should be empty right now because nobody's standing in front of it. Perfect. Yeah, and I'm fine if we don't get the chat up. It would be nice if we could, so that my presenters can have live questions, but I'm fine either way. Okay, so I am clicking in on my phone. And I've got the presentation here. But I don't have any, I'm not seeing any chat options on my phone. Yeah, so I don't think. Well, so we can't tell numbers, but we end up, so the live reports that you give me, it's usually like 40 to 80 or whatever. And then we get 800 to 900 and end up watching it in archives. Right. I know some of the stations broadcast it live over like a network television thing. That would be a computer, but I know a lot of folks just watch it on the fly too. Chat option. remember that. That's what we used to do before we went over to this new platform. Yeah.
It's like up here. Yeah.
Okay. Well, I mean, I think we'll just go ahead with this for now. I'll see if when my friend here can get on PETOS, and send it on to us. See if it works from computer to computer. It's not gonna work. Right. Okay. Yeah.
All right.
Okay.
Sounds good.
Not if we can, but we're okay without it. I've actually got a lot of folks that have my cell phone, so I can use the text.
15-year-old Chris is having a severe asthma attack.
All right. I'm good. Thank you.
Now,
Yeah. Okay, we'll do. Same thing with me. If you see any reports of sound problems or whatever. All right. Thank you. Bye-bye.
I'm trying to connect with Bluetooth, I'm trying to connect as a hotspot, I can't do either, and I think the new computer, I think they disabled
Oh, your hotspot stuff.
I think so, but
Can you see my iPhone? Sophia's iPhone.
I think she's iPhone.
Try getting on that one.
Yeah, I need your,
TTDALRYM.
they all make the book small, TDD,
ALRYM.
and then the Mary.
Yeah.
It's connected.
Hope our crews are coming. They usually don't show up until like 2 minutes before 2, just so you know.
Sounds good. I'm here either way.
Yeah.
I'm not going anywhere.
Pretty sure Helen never mind stuff though.
Oh, sound. The mic right here.
The camera has a mic,
Okay.
so if you're in front of it, it should be good.
Great.
And then you can adjust the camera a little bit as far as just moving the back of the screen up and down to get your whole head.
Cool.
But it has a little window so you can kind of show yourself in that spot.
So, there's a top check, says PETOS admin hello, test.
Okay, so you can see. So now try to say something. Can you
I'm
say
gonna find
something?
it to chat.
So see if. Look, they can hear. Oh yeah, they can hear everything we're saying. It shows up. We have chatting.
I don't know why I'm on YouTube.
Because that's the final that platform that I've set up for the new system.
I don't have a charger for it.
You should probably use that computer. We're going in a few minutes anyway.
How are you?
Good. Welcome.
Thank you.
Over there. Sorry, we should be all just right back here. Okay.
Okay.
We're making our sign-in more.
Oh, are you? Perfect.
To the certificates fast.
Oh, sure.
If this little guy, yes.
I'm Jeff Duff from Thanksgiving Point. We have lots of little ones at Thanksgiving Point, and I appreciate you doing this training. This is great.
We figured we might be a little first since we're coming back from a break.
We're from a break, but surely the firefighters will be showing up, right? We hope.
It should be. I'll do.
Okay, sounds good.
Here, seriously, okay.
Round for that's cool. Yeah. For residency. Yeah. That's good.
Hello, everyone, and welcome to PETOS. After a little break last month, we are back again for our monthly lecture series. Today we have our attending physician from Primary Children's Hospital, Zach Drabkin. He studied at Brown University and then did his residency with the University of Utah. And he's got a reputation already at Primary Children's for being a really, really smart guy. So we're going to turn the time over to him. Stay tuned to the very end. We have a new certificate process, and I want to make sure that you guys understand it so that you can get your CMEs for this presentation. All right, thanks so much for joining us.
All right.
Alan.
Everyone, thanks a lot for coming in and listening. I I got a lot of respect for what EMS crews do. I did an EMS rotation as part of my residency in a residency program. And it was a really eye-opening experience for me. I remember going along with the crews and just seeing what it's like to go out there actually with a totally undifferentiated patients, no vital signs, no IV access. You're playing the role of nurse, doctor, tech, physician, pharmacist, everything all in one. And I am terrified of cats, and there were so many cats in the places we went, and it was really hard to practice medicine in those circumstances. So I have a lot of respect for what you guys do. It's a lot harder than my job, so thank you for doing it, first off. I'm Zach, I'm one of the physicians over at Primary Children's, and in addition to seeing pediatric patients, I see adult patients as well. So a lot of what I do is kind of helping people distinguish differences between pediatric and adult patients. Since most EMS crews see both, I think that's kind of a helpful perspective to have in mind. One thing to keep in mind with kids, Hillary asked me to talk about respiratory emergencies in pediatric patients. And one thing that's always helpful to keep in mind with kids and respiratory disorders is kids are not very good at hiding things with respiratory. They usually will tell you if they're sick by the way they act. So adults have all sorts of other pathology, a lot of psych pathology going on as well that could be contributing. Oftentimes they're habitus and they're other comorbidities make it hard to examine them, use their physical exam. Kids are just right out there. They'll tell you how they're feeling, if they're sick or not. And oftentimes, most of my job is just walking in a room and looking across the room and seeing if the kid is not sick or if they're sick and need some sort of intervention. So what I'm hoping to go through today is first the basic sick, not sick for pediatric patients. When you just walk in the room, what can you tell about a kid to see whether they need an intervention right now or whether they can just have a more thorough workup once they get to the emergency department or their final destination. And then in terms of going through respiratory distress, most of what we do for children is based on our history and physical. Adults oftentimes need lots of imaging and tests and all sorts of other complex studies to figure out what's actually going on with them. Kids, you do good history and good physical, you are able to localize the pathology the vast majority of the time. So going through the tricks about what we can look at our exam, most of it from across the room, to see where our pathology lies, and then talk about some basic patterns of intervention for those different locations of pathology. I don't have any financial conflicts of interest, unfortunately, working on those. And those are the goals we just spoke about. And also the other thing I want to stress in terms of an EMS perspective is that with pediatric patients, the simplest interventions are usually the best interventions. We're not talking about very fancy things for the most part. Usually we're talking about at the most bag valve mask ventilation, but good, effective, simple interventions have the most effect on your pediatric patients. So the pediatric assessment triangle is something that always confused me when I was doing and teaching PALS courses, the appearance, breathing, and circulation. The way I like to think of that is the sick, not sick assessment. It's just you walk in the room, what do you see when you first look at a kid? And usually if you could walk in a room, you can tell a lot of kids by how they're acting, how they're looking, and what's going on. So generally with the appearance you're just looking at, are they interactive like they should be? A normal kid, if you're looking at a normal kid, they should be looking at you, playing around with toys, engaged in their world. They shouldn't be inconsolably crying. They should have a normal tone where they're moving their extremities or playing with toys. For little babies, they tend to be a little bit more flex tone than just kind of floppy extended. So just kind of looking across the room and seeing how they're interacting with their caregiver gives you just a ton of information about that. We'll go through some videos to go through that as well. For breathing, we just look at their work of breathing, their rate of breathing, whether they're having disordered breathing, either they're having pauses in their breathing or breathing excessively fast, and whether they're having retractions. Usually use your diaphragm to help you breathe, and as you have more respiratory distress, whatever the cause, you start to use more accessory muscles. Generally, that tends to follow progression, where you start with your subcostal retractions, and your intercostal retractions, and suprasternal retractions, then a little bit, you can get like head bobbling and nasal flaring. And so we're looking for that as well. And again, most of that is just looking across the room at a kid as they're sitting there, and we'll go through videos of that as well. And then finally, the circulation, that's just looking at how, if they're cyanotic, if they're pale, if they have delayed capillary refill, which is a fairly simple thing to do. Unfortunately, a little bit harder to convey in some of these videos. So going through these videos, these are just videos off of YouTube that I was able to find. So this baby here, if we were just watching this room, say we got called to this kid's house. In terms of appearance, what do you think about their appearance? Yeah, looks good. They're smiling, They're looking around, they're interacting, they're moving their arms and their legs, they appear to have good tone. So just looking across the room, they seem to look like a healthy, happy kid. So your level of stress of worrying about this kid kind of goes down a little bit. Then breathing, you can see the kid breathing, but it's not excessive work of breathing. You don't see any retractions in this case. They're not cyanotic. It looks pretty good from a breathing perspective. And then circulation, they didn't check capillary refill in this video, but just look at the kid. They have pink mucous membranes. They look like they have pink rosy cheeks. They look like a healthy, happy kid. My stress level is low on this situation. Let's take that in contrast to this video here. So this kid, what about their appearance? The first thing that you look at them. Yeah, so you actually get to use the L word here, lethargic. We don't like, that's a naughty word. We don't like using that word unless we really mean it. And this kid, we would use it for. So I like to describe lethargy as a kid who looks miserable but is too tired and exhausted to even fight you. And that's how I describe this kid. So he looks miserable. He looks not happy. He's not smiling, but he's just staring off into space. This examiner is clapping his hands, is trying to interact with him. The kid has no interest in that at all. Also, you notice, if we can go back to play this video again, the kid, at one point, the examiner lifts the kid's arm up, and you can see it just kind of flop down a little bit. He's just moving his arms around. He's got poor tone, and he's just staring off into space, completely unengaged. So this kid, just walking in the room and seeing that, I would be concerned. Sometimes with kids, if they have a fever and they need some Tylenol, they can look a little bit like just kind of blah, but they're usually not like this. Usually they will interact with their caregiver, look around at you, care that you're in the room, but this kid is completely indifferent to the fact that the person observing him is in the room. Breathing, you can't really see much of his breathing because his chest is covered up, or her chest is covered up. But in circulation, the child has kind of a dark complexion, but the mucous membranes do look a little bit pale, and so you could argue that there's some poor circulation. So just walking in the room, this kid, sick, not sick? Sick. You'd be concerned that this kid needs some interventions, and you're a little bit worried about that. All right, here's another video here. All right, so this kid. So first thing, you walk in the room, you look at his appearance. What do you think about his appearance? Yeah, not bad, right? He's playing, he's looking around, he's interactive, he's not distressed, he's moving his arms and legs. So his overall appearance and his mental status look pretty good. I'm not very concerned about that. He's playing with the watch there. He seems happy, engaged, interactive. I'm not really concerned about him looking super toxic. What about the breathing in this kid? Yeah, he is having some retractions. I'll play the video again. They're kind of subtle, but you can see when you look over right at his, oops, let me get that back right there. Sorry about that. So you can see in kind of his ribs, the lower ribs and subcostal area, you can see that he's having a little bit increase of work of breathing. So he is in a little bit of respiratory distress, maybe mild or moderate. It's retractions as we go up the kind of progression of retractions. It's not super bad. He doesn't seem like he's dyspneic. He has some mild subcostal retractions, maybe a little intercostal, but not really suprasternal. He's not nasal flaring. He's not head bobbing. He looks comfortable. So I would say he's maybe mild, moderate, increased work of breathing, but nothing too bad. And circulation, you're not checking the capillary refill here, but he seems to have pink mucous membranes. He seems like he's well perfused. I'm not really worried about that. So in terms of our sick, not sick continuum, he's not completely well, but I wouldn't call him sick. We're worried about this kid and we need to immediately intervene on him. All right. Sorry about the flashing light. There's just a fluke of the video, but what do you think about this kid, just looking at them across the room? So appearance, yeah, it kind of looks a little bit uncomfortable. It might be part of they're sleeping, but they just don't really look as engaged and interactive as you expect for a kid even this age. Usually at this age, even you expect them to, coo or look around or something, but this kid's just kind of out of it. So they're either sleeping, which they could be, that could be part of it, but it could be that they are just not as interactive. How about their work of breathing in this situation, even with their clothes on? Yeah, you can see even with their clothes on across the room, just walking the room, you can see that this kid's working hard to breathe. So you're with the head bobbing, the suprasternal retraction. So your level of like, oh, respiratory distress concern might be a little higher. Plus, you don't know about how that appearance was. And in circulation, we can't really assess from the video as well. But so this is a kid in terms of sick, not sick. I'd be a little more concerned about this kid walking to a room like that, especially if they're lethargic and having increased work of breathing. That makes me a little more concerned. All right, a couple more of these videos just to get the general sense. So this kid here, what about their appearance? A good tone. Also, they look kind of miserable. They don't look like a happy, smiling, interactive kid. Granted, they're getting IV start. They're not really fighting that IV start so much on that right arm. They're kind of like just letting it be almost. So that always has me concerned when kids are not. I mean, if a kid's screaming because I'm looking in their ear, that doesn't mean that they have a bad appearance. But if we're starting an IV and they just don't care, that's usually not a good thing. They should care and should be mad and angry, but then console easily when their caregiver holds them or calms them down. This kid's not quite like that. So their appearance is not terrible, but not great as well. How about their breathing? Yeah, you can see some decent retractions going on there as well. You see some subcostal, some intercostal, some suprasternal. And this is, again, across the room, no stethoscope, just kind of what your general impressions are. And again, circulation, we have difficulty assessing unless we go up and actually test their capillary refill or look at their perfusion. And here's one more example. So in terms of their appearance, yeah, so they're coughing. They look kind of miserable, but they're not really like, you know, they don't seem like they just don't seem like they're doing that well. They just look miserable. They're not really engaged. They don't look like they have much fight or energy in them. Breathing, yeah. So like little staccato breaths with retractions that you can see as well, with a fast respiratory rate. So I'd be concerned about this kid's breathing as well. And then circulation, again, maybe you can argue this kid's mucus memories. You look at her lips and looks a little bit pale there, so there might be a little bit of decreased circulation. So sick, not sick, walking into the room, sick. I'd be concerned about this kid walking in the room. So the pediatric assessment triangle is something that always kind of confused me, and I just think of it as sick, not sick when I walk in the room. So I walk in the room, do they look like a normal, happy, healthy, interactive kid like that first video that we saw, or is there something that we need to intervene on sooner than later? Is it that they're not fighting like they should, that their tone is poor, that they're inconsolable, that they're working hard to breathe, that their circulation's bad? Any one of those things means that we need to heighten our level of alert and figure out what's going on. In terms of respiratory distress, we kind of spoke about retractions kind of following a pattern usually. Usually we see that retractions start a little bit lower and work their way up. So we usually start with subcostal retractions, which is basically the body, and all these retractions are using extra muscles to exchange oxygen and carbon dioxide. So usually your diaphragm does that work. In these cases, you have to use extra muscles, and as the more muscles you use, the more obvious it becomes. So oftentimes we'll start with those subcostal retractions, a little bit lower here, just below your ribs. Then you can see the rib muscles, and then the suprasternal, and then working up to seeing some head bobbing and nasal flaring as well. So just in terms of a few videos kind of highlighting that current slide. Let me start that up again, sorry. So this here is an example of some subcostal retractions. So you can see this kid, each time he breathes, his belly is moving significantly. So it's not just his diaphragm, this subtle breathing, but you can see his belly moving each time, maybe a little bit in between the lower ribs as well. This baby here has some intercostal retractions as well, where you can see the muscles between the ribs moving each time as well. You can see his sternum moving as well. In terms of his appearance, going back to that sick, not sick kind of spectrum, this kid is looking around. He seems interactive. He's consolable. He doesn't seem that miserable, like he has no fight left in him. He seems like he's doing okay, but he does have some moderate respiratory distress. So this is a kid that we'd have to intervene on, but I don't feel like he's crashing right now in front of us. And then this kid here, so we see some subcostal retractions. We see some intercostal retractions. For a child of this age, they're not as pudgy as we expect them to be, so that's something that's also a little concerning as well. Then you can see some suprasternal retractions as well. And again, this kid here, you can't really see from the video since it doesn't show the face if they're awake or not, but just looks like they're blah, have no fight. I'd be concerned about this kid with 3-point retractions and just looking like they're kind of listless, lethargic, not well-looking kid. And also, in this case, the kid is much skinnier than I think they should be for a child this age. Next thing to think about, once you identified that a kid is in some sort of respiratory distress, and usually they'll be pretty obvious with that the rate of breathing is off, or that they're having more retractions than you'd expect, or more increased work of breathing. The next thing you can do with your exam is to try to localize the pathology. And again, a lot of this is looking at a kid across the room. You can tell a lot just by watching them breathe across the room. There are some general rules of thumb in terms of where pathology is located based on sounds that kids are making. So snoring sound or stuttor, and stuttor is just another word for snoring when you're awake. It's kind of that pug dog breathing that sometimes little kids have. That generally localizes to the oral pharynx. So kids with sometimes kids with a retropharyngeal abscess may present with that, as with stuttor as a presenting symptom. Sometimes just having some airway obstruction when they're sleeping can cause some snoring as well, but that tends to be an oral pharyngeal thing. And that snoring sound is what you think of snoring. It's that kind of like pig noise, pug dog snorting type sound. The next, as we move down through the airways, we kind of get to the stridor sound. And stridor sound is that high-pitched squeak, usually inspiratory sound, and it kind of sounds like it's kind of a squeaky sound when they breathe in. It can be with expiration as well, depending on the location and the degree of the stridor. It tends to localize around the vocal cords. Once we have a biphasic stridor, which is an inspiratory and expiratory stridor, that's when you get the we usually think of it being at the vocal cords, or like right at the vocal cords or right below them. Classic example of that is an airway foreign body can cause, in the upper airway, can cause that biphasic stridor. And then finally, once you get below, if you don't have those things, you kind of have to use your stethoscope. So this is the first time we're actually using our stethoscope, really, is to see whether it's wheezing or more of lower airways. And that's not even a perfect test necessarily, because sometimes there can be some crossover between those two. So a wheezing sound is most classically in the bronchioles or bronchus, and it tends to be an expiratory sound and tends to have this kind of high-pitched whistling sound. So it's kind of like a like that. And we'll have some videos where that's obvious as well. And then crackles is sometimes usually in lung pathology, the lung tissue itself, the alveoli, and that is like crunkling a piece of paper is how it can be described. Or sometimes if you grab your hair and just rub it like that, it sounds like that a little bit, if you rub your hair right next to your ear. And that tends to localize to the lung tissue themselves. There can be some overlap though. So oftentimes with broncholytics, you will have scattered wheezes, and often, sometimes with asthmatics, you'll have some crackles that open up when the airways open up. So it's not a perfect test, but it helps guide you somewhat. And then finally, the last thing is disordered control of breathing. Sometimes kids look like they're in respiratory distress or are not breathing well enough, and it's not necessarily a result of the respiratory system itself. Sometimes it's a result of disorders with the respiratory drive, either from abnormal signals in their brain, from toxins, from metabolic causes, and we'll go through some of those as well. But when the picture's not adding up, but they're still not in respiratory distress, that's when you want to start thinking about those other pathologies, and we'll go through some of those as well. So now we've kind of localized what these pathologies are based on your just very simple physical exam, and again, most of it from across the room, just walking and seeing a kid. There's several simple interventions that you could do to fix these. So usually when it's upper airway and you're hearing snoring, the first thing you do is position the kid better. So you might, if it's a kid who's asleep and snoring, you might need to give them a little bit of towel roll under their shoulders if it's a younger kid. They might need to suction them if they're having a bunch of upper airway secretion sounds as well, like just suction their upper airway, or their pharynx rather. If they're having a stridor, the most common cause is croup, and we'll go through some of the other causes as well. And the treatment is usually has to do with racemic epinephrine and steroids, and we'll talk about some other things you can do as well. For lower airway, that's where we kind of have to make a decision: are we treating more of a bronchiolitis type picture or a viral pneumonia type picture, versus are we treating an asthma type picture? And if it sounds like a good story for asthma, usually an older kid, prolonged expiratory phase, wheezes, then we would do things like albuterol, steroids, and then we can think about more advanced things like non-invasive pressure ventilation or magnesium. For broncholytics, if it's just that younger kid with intermittent crackles and wheezes and increased work of breathing, then the first thing to do is suction, and then think about things like high-flow nasal cannula or CPAP, BiPAP as your interventions as well. And most of the time, those interventions are all that you need. It's pretty rare that you have to intubate kids in either one of those situations. And studies that have looked at management of airway in the field in EMS, or at least one big study, found that bag valve mask had better outcomes than intubation. So again, simple interventions are the most effective ones. And finally, disorder control of breathing. Never underestimate how powerful a good bag valve mask ventilation is. So for kids especially, they're usually pretty easy to bag. So if they're not breathing well enough, they're breathing too slowly, you can always breathe for them with that simple bag valve mask ventilation, and think about reversal agents if there's any underlying cause that needs to be reversed. So for stridor, we talked about stridor. It's kind of that inspiratory upper airway squeaking sounds that usually localize the upper airway. Infection is kind of the main cause of stridor. That's the most common cause. And among the infection, croup is by far the most common infectious cause. It's usually a viral infection. It's usually the same viruses that would give an adult a cold, but then for a kid, it causes a little bit of narrowing in a very small airway. So generally, your airway is the size of your pinky. For us to have a little bit of inflammation from a virus, it's not that big a deal. For kids, all of a sudden that little airway turns into a really little airway, and you start to have a lot of turbulent flow and a lot of trouble moving air as a result. And that's what causes the barky cough associated with croup. It's what causes the stridor, the high-pitched inspiratory sound associated with croup as well. And the treatment for croup is really supportive care. So we do things to help reduce inflammation in the airway. Steroids are the best in terms of long-term, but they take a little bit to kick in. So if we need a little extra help, that's when we use something like racemic epinephrine. We'll talk about that a little bit more as well as we watch some videos. Bacterial tracheitis is something an entity that people are becoming more aware of over the last few years. In Utah in particular, we've had a little bit of an outbreak of bacterial tracheitis about 3 respiratory seasons ago, where we had just a ton of cases. And that one can be really tricky to diagnose. Oftentimes, kids with bacterial tracheitis present a lot like croup, but it's just a little bit off. So, for example, kids with croup tend to outgrow croup by the time they're 6, 7, 8. By the time they're that old, their airway, their pinky-sized airway is big enough so that the inflammation doesn't really cause a problem. With kids with bacterial tracheitis, if an older kid has something sounds like croup, you always want to think, could this be bacterial tracheitis? If you have a kid who's not responding as you'd expect to normal croup treatments, that's something that will make you think about bacterial tracheitis. If you have a kid who, for example, you gave them multiple doses of racemic epinephrine and croup, they usually have a really quick response. I mean, within minutes, you'll see a difference. With bacterial tracheitis, oftentimes they won't necessarily. And sometimes it can be a little bit of a wet, like kind of a wet, gunky cough because they have this bacterial exudates that they're coughing up as well. But that's one that it can be a very tricky diagnosis. But from an EMS perspective, your interventions are usually going to be pretty similar to croup, that you're going to give racemic epinephrine, try to keep the child calm and comfortable and get them to definitive care. Epiglottitis is something that we used to worry about a lot more than we currently do. If you look at our Intermountain data, for about every 1,000 cases of croup that you'd have, you might have 10 cases of bacterial tracheitis and 1 case of epiglottitis. So it's become a lot less common. It tends to present with rapid progression of disease, with a hot potato voice, inability to manage secretions, and oftentimes with stridor and high fever as well. So these kids look very toxic. Again, it's not as common as it used to be, and you're far more likely to have croup or bacterial tracheitis or even an airway foreign body than you are for epiglottitis at this point. And again, these are kids, if you do suspect a kid has epiglottitis so that they have a hot potato voice, they're drooling, they're tripoding, all the things that would make you suspect that. Your interventions in the field are really not that much. You're trying to keep them comfortable, maybe some racemic epinephrine, and get them to definitive care, because these are critical airways that are, you don't want to handle in the field if you can. Palpitative voices, like this. We'll have a video that kind of goes over that as well. That just shows that with a kid who kind of has that, like, they just took a bite of something hot and are blowing it out. And then whooping cough is the last infectious cause that's worth talking about in terms of a cause of stridor. So a lot of what we do in pediatric emergency medicine is give Tylenol and slushies while vaccines do most of the work for us. And this is a case where that might not work. Where there's whooping cough vaccine, it's not 100% effective. It kind of relies on big groups of population getting the vaccine, and as vaccination rates have gone down, more kids could have the potential to be exposed, even if the vaccine is not 100% effective. So the whooping cough 10% usually starts off like a regular cold, where you have cough, runny nose, feeling miserable, and then it just goes on and on and on and on, and it lasts for months, and it's just terrible. So the way you kind of present with whooping coughs, these what's called paroxysms of cough after the first couple of weeks, where you have these fits where you cough, 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 and then you breathe in with this loud stridor. So that goes on for months. It's terrible. You have post-tussive emesis. The thing that's really scary about this is for little kids, you have really awful complications of whooping cough. So for little kids under 1 year, they're prone to have apneic episodes that could require them getting intubated ultimately. You can have pneumonia as a result as well. And then finally, the thing that's also concerning is you can have a severe leukocytosis that can cause thrombosis as well, including strokes and stuff like that. So it's a pretty nasty disease when it's out there, so something worth keeping in mind. So if someone's had a progression disease where they just have this relentless cough that will not let up, and we'll play a video where we show that paroxysm with the whoop at the end, that's something that's highly concerning for that. So let's watch some of these videos real quick, so we can kind of go over this down. So we'll talk about the rest of that, the rest of the causes of stridor that are worth considering when it's not an infectious cause. So this kid here, this one has some sound. Yeah, so that's like the classic like barking cough that we see with croup as well. It's not the whooping cough where it's cough, 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 and then a stridor, but just a little bit of that barky sounding cough. So this is a croupy cough, and oftentimes, again, just walking in the room, you can hear a kid cough a couple times, you can know that's what it is. This is an example of some stridor. This kid had croup. He didn't have any barking cough episodes. Usually, if we see a kid with croup who has stridor, that's kind of our sign that we need to start doing something about it, and more immediately. So a kid just comes in, that first kid with that barky cough, or is that kind of intermittent barky cough, we can give them some steroids and send them home and have them follow with their pediatrician. Oftentimes, croup, you'll see, you guys have probably seen this as well in the field, that we have kids come in who they have that barky cough, they have stridor at home, they look terrible at home, their parents race them into the car, and they get to the ER and they look like $1 million. And that's very common. We expect to see that just because the cool air will just oftentimes give enough of a reduction in inflammation to kind of calm things down and make them look better for us. So again, it's something that's where we see a big difference between parents' perspective, the EMS perspective, and what we actually see in the emergency department. So if you see that, don't be shocked by that at all. The kid looks significantly better with croup by the time they get to us, just by the time they get some cool air from just walking outside into the EMS rig. This kid here, so this kid, going back to what we were talking about earlier, kind of toxic looking. They're interactive, not interactive, they're lethargic. They look like they look miserable but don't have any fight left in them.
At all times through a widely open mouth. Characteristically, at no stage does he swallow, and although it's not evident on the screen, saliva was seen pooling in his mouth.
So that's an example of like a fairly toxic-looking kid who in that case, had epiglottitis. So that was the kind of that hot potato voice. you can hear a little bit of stridor in there, but just very toxic looking, ill appearing, and then the drooling of secretion sitting up in the position of comfort. That's a critical airway. Just come in, keep the kid calm, try not to do anything to piss them off, and get them to the emergency department. Those are kids we don't even try to intubate. We would never try to intubate in the ER without calling a surgeon who could do a crike and an anesthesiologist in as well. Those are critical airway, high stakes situation, nothing to mess around with in the field without that kind of backup if you could at all avoid it. And then this is an example of whooping cough. I'll play the whole thing because it is painful to watch right now. There's that little whoop, little squeak at the end there. That's like that for months. It's really terrible, and oftentimes kids will end up in the hospital for months. So whooping cough is, for older kids it might not, or for adults it's annoying because it still lasts for months, and it's still really annoying to have those paroxysms of cough and feel like you have a cough that goes on forever. For little kids, it's actually quite dangerous and something to look out for. So if you see that kind of pattern of symptoms, it's something to keep in mind. And then again, if you see that pattern in a younger kid who's under 1, you have to think in mind about the sequelae that you can get: pneumonia, apnea, and thrombosis as a result of having a leukocytosis or super high white blood cell count. So those are kind of the main infectious causes of stridor and upper airway problems. Other things to think about: choking is a really common one. Choking, like we said, it can cause a fixed stridor where you have an inspiratory and expiratory stridor. If it goes a little bit further down into the bronchus or bronchial, you can actually get some wheezing associated with it as well. If there's a good story for choking and exam findings, then that oftentimes alone, even if the imaging doesn't show anything, we'll send kids to get scoped with either general surgery or ENT just because of the suspicion of potential outcomes. The one thing that really scares me with choking in particular is organic material. So say a kid chokes on a dry bean or a peanut. Those are things that can sit in the airway and swell for 2 or 3 days. And just like if you soak beans in a pot at home before you cook it, they swell up pretty significantly. The same thing happens in a child's airway. And very suddenly you can have just an absolute deterioration of a child. And most of us who've worked in the pediatric emergency department have seen kids who have been at home fine for a couple of days and come in and just crash really hard. So even if the episode was a couple days ago, especially if it's an organic material that can swell up, that has me on a higher level of concern as well. So just a story of choking is something that you got to take seriously in little kids. And most of you who have little kids probably know that an older sibling is a risk factor for choking because they tend to try to, give them things to eat that they shouldn't be eating. Anaphylaxis is another cause of stridor potentially. Anaphylaxis, technically by definition, has to have 2 organ systems involved. So the definition is like hives plus respiratory stress, or hives plus airway swelling, or hives plus persistent vomiting, or hives plus hypotension, or kind of combination of 2 things. The other definition you can technically have is hypotension that's after known exposure, but that's not really relevant to what we're talking about now because we're talking about stridor. So usually you would see something else consistent with an anaphylactic reaction. So hives, persistent vomiting, there's a known exposure, something that they're allergic to. And in that case, your treatment would be more of the epinephrine, like your usual anaphylaxis stuff, with epinephrine being the mainstay of the treatment. The rest of the stuff we do, the steroids, the Benadryl, the H2 blocker, it's plus minus. You don't really need it as much, but IM epinephrine is your treatment of choice in that case. And again, just like nebulized epinephrine for croup and the upper airway infectious causes, IM epinephrine has a pretty quick effect and has a really remarkable, kids can turn on really quickly with that. And then the last thing that's worth talking about, I don't have any pictures or videos of this, is just anatomic considerations. So if kids have had ongoing stridor for weeks or months, they might have something anatomically going on that could be causing it. So it's worth asking the parents if there's a history of that. If there's a history of prior airway surgeries or prior intubations for a long time. So a big red flag for me with a croup type picture is this kid in the NICU? Because oftentimes kids in the NICU are intubated for a long period of time, and you can develop what's called subglottic stenosis. So that's basically a narrowing of the airway below the vocal cords. And sometimes what will happen is you'll have a circumferential necrosis of the airway there. The kid grows, but that area of necrosis does not grow. And they'll get to a point where they get some minor respiratory thing, and all of a sudden they have just god-awful stridor and respiratory distress. And that needs a major surgery to correct. If you do your basic airway stuff, your decadron and racemic epinephrine, but they oftentimes need more intensive as well. All right. Any questions about what we've gone through so far? No. Okay. Next, kind of working our way down the airways is wheezing. Play this video here.
15-year-old Chris is having a severe asthma attack. His immune system has made what could be a fatal mistake and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely.
So with that kid, what are some things that are concerning about that video with his work of breathing? He has a feeling impending sense of doom. What else? He's tripoding. He has pretty significant retractions. He can't speak. That's a big one. He's speaking in like a few words at a time. I can't breathe out, and that's about all before he needs to take another breath. So he also, if you notice with him, his expiratory phase is significantly longer than his inspiratory phase. So with asthma, it's a problem with expiration. So he'll take a breath in and keep on pushing to get it out. So this is a kid with, looks like pretty significant distress from asthma. One thing, we talked about wheezing being a prominent sign that you see with asthma as well. One thing to keep in mind with really severe asthma, your air movement might be so poor that you might not hear wheezing. So say you have a kid who has a history of asthma, they look like they're in severe respiratory distress, they have a ton of retractions, they're dyspneic, they're speaking in not full sentences, but you listen and you don't really hear much of anything at all. It might just be that they are so shut down in their airways that they're just not moving air, you can't even hear the wheezes. And sometimes you actually start to get the wheezes come out after you give the albuterol. We'll see that a lot in the emergency department as well. So sometimes just the clinical suspicion of the history of asthma or family history of asthma without the cause was enough to make us even think about trying albuterol in these kids to see if they help. And again, simplest interventions are usually the best. The first things we'll do with these kids is steroids and albuterol. Usually we give pretty large doses of albuterol in the emergency department. We'll give like up to 20 milligrams usually for the first dose even. So much more than you typically give for an adult who had like a COPD exacerbation. And kids usually handle that pretty well. If kids have severe asthma that's failing treatment, we can do things like CPAP or BiPAP to help them with their ventilation exchange, because asthma is usually more of an issue with getting rid of carbon dioxide than oxygenation, and that can have a remarkable effect. But from an EMS perspective, while you're getting them to the hospital for definitive care, simplest interventions are usually the best. Usually we'll think about things like steroids if you have the option of giving it, and albuterol as well to see how they respond to that. And kids will oftentimes turn around really well. And then these are some, we talked a little about lower airway with the crackles and the wheeze that we can see with broncholytic kids. So this is an example of a kid with bronchiolitis. So you can see this, even with the gown on, the kid has pretty significant retractions. They have suprasternal retractions, they're head bobbing each time, they're pretty noisy breathing. Seems like they benefit from getting a little suctioning. And just overall, going back to our basic sick, not sick, this kid doesn't have the appearance of a well-looking kid. He's kind of just not engaged, not interaction, doesn't have any fight left in him. He just doesn't look super great. So this is a kid I'd probably be a little more worried about, potentially. One thing that was never stressed to me enough in my training until I actually saw it in terms of what I think is the worst complication with bronchiolitis is apnea. So kids who are ex-preemies or who are less than 44 weeks post-gestational age are at risk for developing apnea with bronchiolitis. It's not really even a factor of how hard they're breathing or tiring out per se. It's more that just the abnormal brain signals for getting them to tell to breathe. So most kids with bronchiolitis can actually hold on for a fairly long time, and usually it's very rare that we have to like rush and crash intubate a kid with bronchiolitis. It's actually pretty rare. Usually we can have plenty of time to try either high flow or CPAP or BiPAP after some suctioning and try a bunch of things. It's very rare we rush and crash intubate a kid. The problem you have with bronchiolitis, where kids actually usually get in the most trouble, is those really young kids, the ex-premature kids who have apneic episodes where their brain they stop breathing. So whenever I see a story consistent of bronchiolitis, that kind of secretions, increased work of breathing, crackles, and it's a young kid, I always ask the parents about have they had episodes where they turn gray, where they're floppy, where they're blue, where they're not breathing. Because if they are, that kind of heightens the level for me, and I'll oftentimes observe those kids a little more closely, admit them to the hospital more often, and or even sometimes need to intubate them if their apneic episodes are frequent enough where they're causing problems. So this is an example of a kid, and they just focus on their belly because you can see that they want to be HIPAA compliant. And there's an umbilical hernia that's completely unrelated here, but you can kind of see this here in this video. So they're breathing there, and they just stop. And again, he wasn't breathing so hard that you think like he's tiring out per se. His brain just told him just basically didn't have him breathe anymore, and then it kind of starts up again. So that's, for me, was like kind of the biggest thing that is oftentimes overlooked with bronchiolitis, is that you can have these apneic pauses that can be really dangerous for young kids. Yeah.
So when the parent tells you you've been doing this, they don't want to be trying to force it, what would we tell them?
I would tell them that kids who are really young, who are at risk for having these pauses in their breathing, just of abnormal control of the brain, and we need to observe them. We would recommend that they come in the hospital because they might need to be observed by a medical team to make sure that if it happens, we have tools that we can intervene. Yeah, if the kid's having apneic pauses, I would not leave them in the field for sure. Even if it just means they stay in the hospital, we watch them on monitors overnight, that's fine, because if this happens at home and happens for too long a period of time, it can have devastating consequences. All right. And then last thing that's worth talking is when we have something that doesn't fit into that categorization. So a kid who looks like they have retractions, increased work of breathing, but their lungs sound fine. They don't have any wheezing. They're moving great air. They're not hypoxic. They're not cyanotic. Then we got to start thinking about other things that could be causing this. So disordered control of breathing is a major category. Oftentimes, so our breathing has several roles. One, we get rid of carbon dioxide with our breathing. Two is we get oxygen in. The third thing is we use our breathing to help control our acid-base status. So our breathing helps get rid of carbon dioxide, which helps deacidify blood, essentially. And sometimes our breathing can be abnormal because of something metabolic that's going on. Classic examples of that are diabetic ketoacidosis, or a salicylate or aspirin overdose can cause that, where we have deep breathing because of acid-base status. And then the other thing is if you have brain damage, so say you took overdose or narcotic, like a child ate their parent's Suboxone or something like that, they can have abnormal signals from the brain that's not telling them to breathe. So that's something to keep in mind. And I've seen this in the emergency department as well, where a kid comes in with respiratory stress, they get triaged as asthma, but when you listen to them, they have no family history of asthma, no history of asthma, their lungs sound clear, and then you get a blood sugar and they're DKA, and that's why they're working hard to breathe. So here's an example of that.
This little guy actually presents here. He's a no-list dependent diabetic, and he's coming in with a pH of like 6.9. He's actually got a little bit of a dental abscess that's kind of kicked him off here. But his breathing is really what we're trying to call Kurzweil breathing, and when you smell his breath, it basically has a very sweet kind of an acetone, ketone sort of odor to it. So he's getting getting a little.
So again, that's an example of disordered control of breathing, causing some pretty significant respiratory distress in that kid, where has pretty significant retractions. His mental state didn't look that great in that video, but this actually was not a primary respiratory problem. It was more of a metabolic problem. And then finally, I've also seen the opposite happen in terms of metabolic control. There's a condition called hypertrophic pyloric stenosis that can happen in kids under 12 weeks age, where they basically get a blockage in their stomach and they vomit up everything they eat. And as a result, they have a severe alkalosis. And so your body's way of dealing with that alkalosis is to hold on to carbon dioxide. So you have kids who can have apneic pauses because of their severe alkalosis as a result of something completely unrelated. So just something to think about, that if things aren't adding up, most of the time kids are pretty simple and straightforward, where you can localize their pathology based on your very simple physical exam without even doing fancy diagnostics. But if that's not adding up, you kind of got to think about, could there be something else going on? Is there some disordered control of breathing? Is there some metabolic process going on? Did the kid get into some medicines they shouldn't have gotten into? They have diabetes? And then finally, there are other organ systems that can present with respiratory distress and disordered control of breathing. If a child has a pneumothorax, if they've had some trauma, if they're older, like a teenage kid who has spontaneous pneumothorax, they might have some respiratory distress without having pathology localized to the lung tissue itself. And again, you should be able to hopefully see some signs and symptoms of that on your exam. So diminished breath sounds on one side, jugular venous distension, tracheal deviation if it's bad enough. Cardiac, that's one that's really sneaky, and I think everyone who's worked in pediatrics long enough has been burned by a tricky cardiac kid. But things to look out for is younger kids, feeding is like running a marathon for them. It's like the hardest thing they do. So if kids are like sweating with feeds and working really hard to breathe with feeds, that's kind of a red flag for cardiac lesions that could be happening. For younger kids who are in the first few weeks of life, it's always important to check their femoral pulses, since you can sometimes have constriction of the aorta or coarctation of the aorta that can cause problems. And then finally, with kids, it's pretty easy to feel the liver, like how far down the liver is compared to adults. And if a kid has a huge liver, and I usually try to start feeling for the liver down at the pelvis and working my way up, because I've had cases where I felt like it's a normal liver, but that's just because I was feeling the liver. The liver is actually way below where my hand was. But if the kid has a liver that's way lower than you expect it to be, that's a little red flag for possible cardiac etiology. And then finally, the last thing that could tip you off at cardiac is that if you're giving them fluids, like IV fluids, and they're getting worse, that's something that make you think of cardiac etiology. So say if a kid who's tachycardic, looks dehydrated, poor capillary refill, you give them a fluid bolus, now they're having that plus respiratory distress. That should make you think about whether there's something else going on as well. And that's a tricky thing. It's hard to diagnose, and it's something to keep in mind, that if you're having sweating with feeds for little kids, if you're having if you're worsening with fluids, or if you're having like abnormal, other signs of heart failure like you'd have in adults, that's something to keep that in mind. And then finally, another thing that can be tricky with kids in terms of respiratory stress is you have some kids who are just hypotonic for neuromuscular reasons. And those kids, if they have botulism or central neurologic process, they might have respiratory distress because their diaphragm's just weak. And it might be their baseline that they have some increased retractions, but these kids usually have a lower reserve. So even if their retractions are just because of their weakness, we still would take that very seriously, and you need to intervene on that. And then the last couple of points, basic interventions. We talked about the simplest interventions being the best interventions. A good two-handed bag valve mask ventilation is probably the best thing you can learn to do for a pediatric patient. Some tricks for that. First off, just keep in mind your adrenaline when you're bagging a kid. Like, it's a stressful situation, and your temptation is to squeeze the whole bag in very quickly, in which case the stomach will become very full of air and it'll be kind of counterproductive. So you want to keep in mind that the person squeezing the bag, who should be a separate person from the person holding the mask, should be doing a volume that's appropriate for the kid, just enough to get some chest rise. And then the person holding the mask, this is the type of grip I like to use, where you put your palms against the mask and then grab the angle of the jaw and pull it towards you. So the mistake I see people make is they push the mask into the child's face, and that kind of pushes their neck like this and just pushes air into their stomach, essentially. You kind of want to pull the face up into the mask with a good jaw thrust, a good two-handed jaw thrust, where you get behind the angle of the jaw and pull it towards you with both your hands like this while keeping a seal with the mask. So again, it should be a two-person job. One person holding both their hands, palms against the mask like this person does in the video there, fingers around the angle of the jaw, pulling the head up towards the mask rather than pushing the mask into the bed, which kind of opens up the lower, the stomach and pushes air into the esophagus. If you want to try it, do it one-handed. You can do it one-handed, but with the adrenaline going on, this is such a crucial intervention. You just need to get good, effective vaginal ventilation. One thing we have the luxury of seeing in the emergency department is after kids have come in with respiratory failure where they're needing lots of bag valve masks from EMS, from us, from anyone, is their stomach is huge from the amount of air that's going in. Sometimes it can be so big that it makes it difficult for us to ventilate. And that's not just EMS, it's what we're doing in the hospital as well. So good, effective bag valve mask ventilation is one of the best life-saving interventions you can have in a truly sick kid. And then finally, for positioning a kid, that can be a little bit tricky and a little different than for adults. Kids have such a big occiput that if you try to put them in that traditional sitting position, that might not necessarily help things. So this is kind of a diagram showing that. This first picture is the kid lying down, and his head is so big that it kind of pushes his chin into his chest and closes things off. If you did the traditional towel roll that you see with adults, which I'm a big fan of. I really like doing that in every adult I intubate. I always put towels underneath the head before intubating. It kind of almost makes things a little bit worse between if you're opening up the airway, you're kind of creating more of an angle there. Versus in this case, for this kid with this big occiput, you put a little roll into the towel that might help open things up. Either way, you're still aiming usually for an ear to sternal notch type situation, but sometimes you have to do that in a low position. Another trick for that is if you have a kid who is awake, so if the kid's like lethargic, limp, you need to position them. If they're awake, it's usually better to let them be in a position of comfort. You don't need to force a kid with respiratory stress to lay down. If they're more comfortable and calmer in their mom's arms, that's great. Leave them in their mom's arms. If they're better sitting up, that's great. Leave them sitting up. Nothing says you have to lie a kid down in that situation. So if you were to summarize kind of what we're looking for with respiratory distress, the first thing is most of our sick, not sick assessment is just walking in the room, looking them across the room. For respiratory distress, we have signs and symptoms we can associate with respiratory distress, like retractions, increased work of breathing, dyspnea. And then we can localize our pathology based on what we're seeing with our airway sounds, most of it from across the room. And going through those again, snoring and stridor is usually oropharyngeal, stridor is upper airway, wheezing is bronchioles, bronchus, and then crackles is the lung tissue itself, kind of working our way down. And then each of those have different interventions. For upper airway, it's usually positioning and suctioning. For stridor, if it's infectious, it's usually racemic epinephrine, keeping them calm, and steroids. If it's anaphylaxis, then you treat with epinephrine. For asthma, we have our lower airway stuff, which is like asthma and bronchiolitis. We kind of treat this a little different. Asthma would be steroids, albuterol. Bronchiolitis would be suctioning, high flow nasal cannula, or CPAP, BiPAP. And then think about, if things aren't adding up, think about your other options, your disordered control of breathing, your metabolics, and your other organ systems that can present as respiratory distress. Any questions at all?
We do have a lot of folks that will pull out Numerol for any kiddo that's respiratory distress.
Yes.
Is there harm in that?
Probably not, but it might not necessarily help. So going through the different causes, if you're having stridor, if you give albuterol to stridor, that really won't help much. It doesn't. It usually helps with bronchoconstriction lower down. Oftentimes, if kids don't like the albuterol mask, and they might get more agitated and crying and become worse because of that. And if the stridulus, really racemic epinephrine is going to be your first choice. Kids usually handle albuterol pretty well. There's some theory I've heard of croup getting worse with albuterol. I don't know if I haven't read the paper, so I don't know the full evidence behind that. For bronchiolitis, sometimes if you give albuterol, you can make things a little worse in that you can have some shifting and VQ mismatch where you have blood going to the part of the lungs where the oxygen is not being delivered, and all of a sudden a baby who wasn't hypoxic may become hypoxic. So it's a harm in that it may cause us to worry a little bit more, but it doesn't cause like a significant long-lasting harm usually.
What are your thoughts about low-fi?
If the kid is needing extra oxygen and they don't require a mask, I'm totally fine with it. But you just got to think about what you're hoping to achieve with that. So if you're hoping to achieve better oxygenation, that they're hypoxic and they are not tolerating nasal cannula, that will work. If their problem is that they need extra support to help them breathe and that they're not exchanging air, they're not getting rid of carbon dioxide, blow-by won't do anything. And any questions from online at all? All right. All right. Sounds good.
Thank you very much.
Thank you.
We'd like to thank Dr. Drapkin very much for presenting. We will be presenting next month, second Monday, as always, at 2 p.m. You'll note that from this next slide, and also from our PETOS website, we have a different pathway for getting our certificates. Those who are live in the room get them automatically, so easy peasy there. And we invite you to come and join us live. It's a lot more fun, I think, and an opportunity to talk face-to-face with our doctors and presenters. But if you can't make it live, we're happy to have you online. If you're watching today, you'll need to answer 3 questions that I'm about to announce and send them to the email listed below, utah.petos@gmail.com, and I will return your certificate to you via email. It does take about 4 to 6 weeks. I try to get it done faster than that, but I'm giving myself a pretty wide leeway there for busyness. So the questions for you guys that are watching live today. Respiratory distress is a progression that starts from lower subcostal retractions and goes up as it worsens. Is this true or false? Number 2, snoring and stridor localized to what area of the airway? And number 3, blank is like running a marathon for infants. Sweating a lot during this activity is a red flag for cardiac causes of respiratory distress. Those will be written down. If you want to email me, I could email them back to you. And anyone watching in archive will also need to email me, and I will send you questions. It's just a verification that you're watching with us. We are appreciative of the fact that you are, and we hope that you continue to join us. Thanks very much, everyone. And we're clear. We always end up recording way too long after the fact.
Jeff, Thanksgiving.
Cool.
If you're ever, shoot me an email or a text or something. The butterflies.
I've heard great things, and my friends the butterflies.
Butterfly exhibit is fantastic.
Well, why don't you send me a
Thank
text
you.
and tell me when you'd like to come.
Oh,
We'll get you out there.
Awesome.
Thank
Thanks a lot.
This is a great resource for me. We see lots of kids and stuff. I'm not on the ambulance crews and stuff, but I've got 7 minutes before the ambulance